So I will be talking about really no blood management in pediatrics, as Susan addressed it. I'm talking today about anemia in pediatrics and a rational approach. I'm not going to really talk about actually managing anemia, but regarding what it means. What do we mean when we say anemia in pediatrics? Why do we worry about this? Because blood supply is not a safe-proof product. Sometimes we have shortages. I happen to live in an area where I have not seen a single shortage. But you guys are not very far from New York, which years ago there was a lot of shortages and procedures being canceled. So that's kind of up and down depending on the market of the blood banking industry and the demand and the supply. Safety of blood, as you've heard, is a relative thing. We think it's safe to the things that we test for, and we don't think it's safe for the things that we don't know of. Sometimes finding the right blood product that matches our patient is a tough thing. Or sometimes when you transfuse somebody who has certain conditions, is not really the right thing to do. If you have an autoimmune hemolytic anemia, you try not to transfuse those. The more blood you give, the more fuel you throw in the fire. Then at the end, the issue that you are all familiar with, sometimes it's not an option in adults, and in kids it's still not acceptable to certain families. However, we can say it's as obligatory situation as it is for adults. However, it deserves our consideration, our serious consideration. When I think about hemoglobin, I'm thinking a lot more about hemoglobin. So anemia is not low hemoglobin. We really worry about a lot of things that go along with the low hemoglobin. Hemoglobin in and by itself is a funny molecule. It's an oxygen carrier. That's what you guys are concerned about. However, it's also a carbon dioxide carrier. It's a nitric oxide regulator and carrier and ATP producer. So really it does a lot of functionality that not everybody is familiar with. And that functionality happens within the cell, the red blood cell, the interesting cell that carries oxygen to all over the body, that doesn't have an aerobic metabolism itself, doesn't have mitochondria. It's very interesting. It doesn't have a nucleus, doesn't multiply. There's no DNA, so it uses actually energy in a different way called the pentose shunt. So it's a very funny evolutionary structure. And all go along, not just the hemoglobin, not the red blood cells, is how it goes through the microcirculation. You heard Steve earlier saying that red blood cells is about 7-8 microns, the capillary is about 4 or 5, up to 7 microns. So really it has to be squeezed in. Microcirculation sees the red blood cells one cell at a time. And actually, when you become anemic, the microcirculation is not going to see this right away because it's still one cell at a time. And the lower the hemoglobin is, the thinner the blood and the more flow. So you there's a lot of tissue compensation that make up for any significant drop of hemoglobin, especially give it time to adapt. So we know it's just not even the hemoglobin or the red blood cells or in the microcirculation. It's the interaction of all these factors under certain conditions. If you have ischemia to an extremity, for example, the hemoglobin will release nitric oxide and will give you vasodilation. So it has a role. But if you have a lot of ischemia and you're damaging that pentose shunt mechanism and the respiratory mechanism for energy production in the red blood cells, you can end up with rheological changes. So the cells are stiff. The cell wall is stiff, doesn't squeeze into the microcirculation. And that's something that Steve hinted to in terms of stored blood will do exactly the same. Sepsis, you have just hemoglobin that lets go of the nitric oxide. You get that vasodilation that's uncontrolled and shunting the tissues sometimes. So I think it's not just the hemoglobin that we should be worried about, is the interaction, the functionality of the system. We know that the more hemoglobin you have, it's not just hemoglobin, it's really, we worry when you say anemia, we worry about oxygen delivery, and oxygen delivery is your cardiac output and how much hemoglobin you have and how good the oxygenation of that hemoglobin. So if you assume you have normal heart function with a good cardiac output, and if you have good lung and normal oxygenation, the higher hemoglobin, the higher the oxygen content in your blood. It's just linear relationship. More hemoglobin means more oxygen to the tissues. Is that true? It's true to a certain extent until you hit about 40 to 45. Hematocrit, then everything after that goes down. The oxygen delivery goes down, even though your content in the blood goes up. And the reason for that is blood becomes more viscous and your blood flow goes down. Opposite of this happens. When you have anemia, you have thinner blood flow will increase. You have some increased respiratory effort. Tachypnea is something we don't talk about much really with regard to anemia, but anemic kids are tachypnic. They have that hypoxic stimulation and they breathe faster. Their cardiac output will go up, mostly with the heart rate, not really with the stroke volume. And the tissue will extract more than what they usually do. And there is some auto-regulations. There are certain organs in our body, the brain and the bowel, they will adjust to certain perfusion conditions. So when that is really disturbed, you can risk having necrotizing enterocolitis in premature babies. But really, you can change your blood pressure, your oxygen delivery to a great degree without affecting, let's say, your brain blood flow because of that autoregulation. So there's some compensation that takes time. So compensation is okay, and it's not really an indication to transfuse somebody as long as there is no evidence of decompensation, and as long as you're doing something to try to alleviate the problem, because you leave somebody in compensation for a long time, inevitably they will run out of energy in terms of that compensation. So all this, you have to put it in perspective. It's not the oxygen delivery, really. Forget about what I said about oxygen delivery. It's about the relationship between the oxygen delivery and the oxygen consumption. And we all know that under normal physiologic conditions, we deliver a lot of oxygen, way beyond any limitations on your oxygen consumption. However, under certain circumstances, like some subgroups of sepsis, that curve is shifted upward, meaning that the point of inflection where any drop in your cardiac output will affect your oxygen delivery is a little bit at a different point. So that's why people think when you have sepsis, you need a higher hemoglobin. I'll give you some data on this in a little bit, but it's not exactly true because there are some patients with sepsis, it doesn't matter how much hemoglobin they have, they just don't increase their oxygen consumption. They have metabolic shutdown. So it's all about really the relationship between the oxygen delivery that's affected by your hemoglobin level, your cardiac output, your good lung or bad lung, and in relationship to your oxygen consumption, which really affected by certain conditions like shock, burns, trauma, growth. Actually, kids who are growing fast and catch-up growth, especially in premature babies, they have higher oxygen demands, or the surface area. The smaller you are, the bigger the surface area that you have, so the more oxygen demands that you will need. So how low can you go with anemia? That's the very old sentence there. I really don't know. I think this was a famous phrase in the early 90s, and Richard Weiskopf did try to explore this in the early 90s, where he got a bunch of healthy firefighters and some healthy patients going to surgery and drop their hemoglobin by taking blood out and give them fluids, taking blood out and give them fluids until he dropped their hemoglobin from 15 down to 5 grams, trying to reach that inflection point that I was referring to. Well, yeah, they found that they fairly compensated with very minor aberrations of their physiology or their mentation. The problem is we can do this in pediatrics. It's not ethical. There are no young firefighters. We don't send young kids to fight fires. So we're talking about different model. And unless you have the right model in terms of developmentally, the nature of the illness, severity, and the stability of the illness, you cannot draw the same conclusions. And as my colleagues earlier said, we do a lot of the stuff that we get from the adult world, but it's not really a kosher thing to do. It's just the best thing we can do at this point until we know better. Some of the developmental concentrations we worry about between differences between adult and pediatrics, the kind of hemoglobin. You've seen that curve there. I think Steve showed that curve, the hemoglobin dissociation curve, and how stored blood will have different curve of shifted to the left, meaning that the hemoglobin doesn't give up its oxygen very well. Well, newborns will have hemoglobin F, or fetal hemoglobin, that has high affinity to hemoglobin. So really, it's very good in utero when you have very low oxygen tension in the placenta to pick up the oxygen. But as you come out, really there's plenty of oxygen in the environment. You don't need that, and it becomes a disadvantage because the tissue will have to extract the oxygen from the hemoglobin at a very low PO2 level. So the tissue will have to get to a lower level of hypoxia before they can extract that oxygen and unload the hemoglobin oxygen content. Hemoglobin synthesis go through cycles. It starts in the yolk sac, then to go to the liver, to the bone marrow. So there's some evolution component to this, as well as erythropoietin that starts being manufactured early in pregnancy, actually in the placenta, to the liver, then before it moves to the kidneys. This erythropoietin has a lot of other roles that we don't understand in terms of development and differentiation and angiogenesis. So it has a lot of other things in the development beyond just the hemoglobin. The cardiac output in neonates is limited. They already have a high heart rate, and they cannot increase their cardiac output the same way an older patient or an older adult can do. We can increase our cardiac output by about 300%, but you get a neonate, there's about 50% increase in the cardiac output when they really need to. So these are some physiological limitation on their degree of compensation. If the neonate's heart rate of 130, 140, how high would it go to increase the cardiac output? 180, 190, 200. So it's a very high heart rate to the point beyond the efficacy of that contractility to squeeze enough blood, because you beat your heart fast enough, you don't have enough time to relax and fill in with blood to have enough stroke volume. So it becomes a disadvantage at a very high heart rate. So age matters, I guess it does, from what I said. Not only that, smaller size means smaller blood volume. And also smaller size means go along with like premature babies, they have frequent lung disease. So very often we're dealing with multi factors here. They're sicker, they have a lot more phlebotomy. And then on top of this, there's some evolutionary component. We don't know its impact until very late, way beyond when they are in the neonatal unit. Development, brain is still developing, the lungs still developing. So whatever we do to them in the neonatal unit can impact the rest of their life. And that's why you probably, all of you had frustrating confrontations with neonatologists, because the neonatologists feel like they have to be very careful. They are very conservative people. And I happen to be one of them in my old days, so I understand that, because not dealing with this now, dealing with an 80-year-old guy who has another 5 or 10 years of life expectancy, you're talking about somebody who potentially have 80 years of expectancy and need to be productive in the community, and have normal social life, IQ, and functionality. So there's a lot of consequences here that we are dealing with. And that's why you can fight with the neonatologist about, okay, they want to transfuse a neonate, a premature baby, because the hemoglobin of 12. It's like, you've heard all this morning about all this safety of hemoglobin of 7. It's not the same situation. You got to talk about things within that model that you are dealing with at that point in time. Talked about anemia. Well, anemia is not even the same way in every age group in pediatrics. We don't have the 12 in female and 13 in male, like the WHO defined it. Well, anemia in less than a month of age is, as she said, is about hematocrit 40 or hemoglobin about 13 or so. So actually, if you have a premature babies, the hemoglobin of 14, less than 14, you start thinking it's anemia in a premature babies. It's awfully high, but remember, there's other factors that plays into this. And that number doesn't reach adult values until they are 12 years of age. Neonates go through a period of dropping their hemoglobin. They are born and they see a lot of oxygen. They stop making erythropoietin. Their bone marrow is hypofunctional for months, and their hemoglobin will drop. If they are premature, that physiologic component is even steeper. So very often you will see a premature baby getting discharged from the neonatal ICU with a hemoglobin of 7 or 8, and they call this physiologic anemia. We can call it whatever we want. I think it's anemia. And the problem is, if they're stable, they're fine. But when they get sick, that 7 is not healthy. And that's really the problem I have when those kids, they go home and come back to me a few days later with bronchiolitis that cannot oxygenate, and they might have some viremic element. So they are sick. And whatever was considered tolerable is not tolerable anymore given the new circumstances. So very often also those kids early on become anemic because of their illness and a lot of phlebotomy losses. Phlebotomy, you've heard Steve talk about 1% blood volume loss in adults. Trust me, it's as bad as it is in pediatrics, even though we use vacutainers. It's just when you talk about a kilogrammer, premature baby or half a kilogram, their blood volume is 3-4 tablespoons full of blood. So it's kind of, you run out of those very quickly. That's one good reason for early anemia in that age group. Later on, as they have some catch-up growth, they grow so fast, their blood volume goes up way beyond the capacity of their bone marrow to manufacture red blood cells. So if you go from 1 kilo to 2 kilos, you're doubling your blood volume in a matter of a few weeks, while you really can make blood fast enough to keep up your hemoglobin. That's why one of the reasons for late anemia. But then you throw in if they have lung disease and ongoing illness, then they have ongoing inflammation and bone marrow suppression, and becomes very multidimensional etiology for their anemia. And of course, they can have hematological problem. They can have hemolytic anemias, whether enzyme deficiency or thalassemia, or even just something called TEC, where it's just transient suppression of the bone marrow. It just doesn't become active for several months to go, and they can become very profoundly anemic. This is a study from a report, and then the study, the report is from Robin Olds and Nassar Bishara from Albuquerque. The incidence of transfusion is pretty high in premature babies. There's about 400 premature babies being born yearly. That number is a little bit old now. About 300 transfusions a year. It's an estimate. And about up to 80% of infants less than 32 weeks get transfused and get anemic. And about 80% of the extremely low birth weight, those are the less than 1,000 grams, get transfused. 50% of those transfusions are in the first 2 weeks. And this data has been reproduced over and over. Valieva from, I believe, from Seattle published this data a few years ago. And look at the younger, most of the younger the gestational age, the more transfusion, and the more phlebotomy, the more transfusion you have. So blood loss really is one important factor of why those babies need transfusions, because it doesn't matter how conservative you are, you're still draining their blood. Anemia of childhood, similar to anemia of adulthood in terms of you have a bone marrow that's not working, or you're making red blood cells that are being lost due to bleeding, or red blood cells that are breaking down because of hemolysis. However, the critically ill child, things pile up against them. There's so many reasons for them to be anemic. And it's one of those things I deal with every day. They come to you with borderline hemoglobin, as I'll show you in a little bit. They have phlebotomy and procedural or GI blood losses. They have blunted erythropoiesis and blunted erythropoietin production because of the ongoing stress and inflammation. They might not absorb their iron because of the acute illness. And they might have a disease in their bone marrow. They might be a patient on chemotherapy, or have a leukemia where their bone marrow is replaced completely. Or they have some reason for hemolysis. So they can have more than one reason. So they're a high-risk group, obviously. So this is coming out ugly. It wasn't like this on my computer, but I have a PC. This is a Mac. I apologize for this. Yeah, it's anemic. Yeah, that's a good point. 25% of the school-age kids in the United States are anemic. 47% of the preschool-age kids are anemic. And this is even keeping in mind that the definition of anemia in those age groups is even less than the adult. It's 11 and a half in the school age and less than the school age is 11. Even with that much of them are anemic. So we know anemia is common, and we know also it's an independent predictor of mortality in adults. So I'm hedging here because a lot of the mortality data is in adults. Kids, we have morbidity data, which to me, I think it's when your mortality rate in general is low, then you're going after quality of life and injuries and morbidity. So it's a very meaningful endpoint, and there's a lot of data you've seen already from Susan regarding outcome in pediatrics, and I'll show you a little bit. Something very disturbing. This is the data from the American Association of Blood Banks. Every 2-3 years do a survey of the blood centers on their blood utilization. And you might have seen this stuff that came out, and I think this came out in 2013, that is reflective of 2011 data. And it looks like we're using less blood now, thanks to the blood management effort. We went down from about 16 million something to about 13 million something. So it's a good drop. And with that, looked at the pediatric data here in terms of red blood cells. We went down from, I can't see the numbers very well from here, but we went down from about 300 something thousand units to 200 something thousand units, which is not a plausible number, as I said, because the neonatal utilization alone is more than that. So we don't have really good data on blood utilization in pediatrics. A few years ago, David Slonim showed that about 4 point something, almost 5% of hospitalized children get transfused in the hospital. 80% of that is really red blood cells, and 87% to be exact. And we know about somewhere between 55 and 80% of premature babies less than 1,500 grams get transfused. And as for the ICU, we know somewhere between the low teens all the way up to 49% of our patients get transfused, depending on the acuity in your ICU and which report that you take. So, and I'll show you again some data related to this. If you look at patients who go on bypass, well, bypass volume is big compared to the patient's blood volume. The smaller you are, the more discrepancy between the bypass volume and the patient's blood volume. Susan mentioned something about Soren have miniature cell salvage equipment. They also have miniature bypass equipments now that we started utilizing. But it's a big problem because you put fluid and that's bypass circuit and you mix it up with the patient blood, they become anemic right on the spot to the point that you have to transfuse them. And I tell you why we have to transfuse them in a little bit also. I want to show you some data. So in our system, we are 10% of the big system and we use about 21% of the blood supply. So this number here in the table on the right side is far from the truth. So it's kind of, we really don't know our utilization. I wish we had the same IT system that they have at Johns Hopkins. Maybe we can have that in a universal way, then we can get a better idea about our blood utilization, but it doesn't exist. Okay, this is a report that we published a few months ago in the Journal of Pediatric and Neonatal Care on 1 year survey of our neonatal unit, how many admissions we had. We had about close to 1,000 admissions, and out of those, 189 of those were less than 1,500 grams, and those were that we zeroed in on. I had interest to know what are we doing with them and what's their outcome. 56% of them got transfused. If you remember, I said somewhere between the 50s and 80% of those patients usually get transfused. And the average is about 8 transfusions per baby. So it's a lot of transfusions. So it's not just getting transfused, they are repeatedly transfused. And we have data that shows when you transfuse those babies, you do a lot of things to them in terms of inducing inflammation, in terms of altering their immune system and changing their antigenic composition. So it's not really a benign number to look at. And we looked also at the age of the blood while we were at it. It was a very painful process. If anybody knows how to get to the age of blood, it's not a straightforward thing that's in the medical record. And yet, those who got transfused in red, as you see the column, were sicker. They were smaller in gestational age, smaller in size, more ventilators. So really, it's justifiable, obviously. They were sicker, so they had more blood draws, more blood loss, and get transfused. But really, the interesting thing, we started looking at the volume of transfusion and their outcome, long-term outcome. And we found that the more you transfuse, when we did a regression analysis, the more incidence of sepsis, and that wasn't reported in premature babies before, and the incidence of ROP, retinopathy of prematurity, because transfusion and iron has an oxidative stress that probably is behind that, but it's just a theory. But I'm talking about the finding that the higher incidence. And also, there was higher incidence of IVH. IVH is related to hemodynamic instability. You bleed in the brain, and it seems like the more you transfuse, the more you're changing, probably altering blood pressure in a rapid way that in a vulnerable brain that you can have intracranial bleed. And we did a lot of adjustments actually in looking at this data because it's retrospective data, by the way, so it's not really prospective data. However, we limited the analysis to a certain number of patients that have limited number of transfusions and things like that. So we kind of did some adjustment, trying to clean up the bias out of the data. And we looked at the age of the blood, and it looks like when you get to about blood that's in the red column here, reached significance where blood less than 21 days versus more than 21 days had that longer length of stay. If you notice, mortality with transfusion didn't reach significance. So I'm staying away from that word mortality that I mentioned earlier. However, transfusion was related to neck. 76 of those patients developed necrotizing enterocolitis, like the picture that you see on the right side, where the bowel gets ischemic and necrotic and perforates at times. So it's a very serious complication. And actually, some of the studies that did hold the feeding while you're giving blood, the incidence of neck will go down. But also, don't transfuse, the incidence of neck will go down too. This is one of the studies that looked at this. And yes, red blood cell transfusions increase the odds of necrotizing enterocolitis. And this is a curve for almost 24 hours, and it started coming down by 48 hours. So you transfuse, you have a higher incidence, the odds ratio of developing necrotizing enterocolitis. So I'm not talking about somebody who has a necrotizing enterocolitis that gets transfusion. I'm talking about the other way around. If you get blood and if you develop necrotizing enterocolitis, and they are talking about the same thing here. But also out of this paper, it looks like if you are anemic, the lower your hemoglobin, the higher incidence of necrotizing enterocolitis. And the odds ratio is small, but nevertheless, there's a risk, increased risk that reached significance in that study. And again, just like many of the studies that we do in pediatrics, there are a small number of patients. There's about 222 controls and 111 neck. That's decent size for a neonatal study, by the way. This study, two studies here came out not very long ago. I think March and April, or April and May, in Pete's Critical Care, and Susan referred to Demaray's paper. This is the same study, actually, group 1 year prospective study looking at transfusions in the ICU. The incidence of the transfusion was 17% in this population. They had close to a little bit more than 800 patients. And it was associated with all bad stuff, as they mentioned earlier. Adjusted odds ratio for MODS, nosocomial infection, needing for mechanical ventilation, septic shock, and mortality. And here, mortality jumps in as one of the significant factor that's associated with transfusions. The odds ratio, actually, if you don't get transfused, the hazard ratio gets reduced by about 0.7 for length of stay, and for mechanical ventilation, 0.59, and it's all dose response, as you see in this curves here on the right, on the right side. They came back, the same group. They looked only at respiratory dysfunction, and they found that 43% of people who got transfused, of children that got transfused, had respiratory dysfunction, either new or worsening respiratory dysfunction. So there is strong evidence of risk finally in pediatrics. I have data, actually, I'm not showing you for time's sake, in trauma patients and kids with ARDS that replicate this data, but mine is retrospective, so this is even stronger and more recent than the data that I published before. This similar data here, and for time's sake, I'm going to skip. It's in patients who get transfused intraoperatively while undergoing advanced cardiac transplant. And we had Howard Quijano, who was a resident when she was doing this study, and actually presented this data for us in LA a couple of years ago at SAPM. So with that, let me kind of pause and tell you about an experience that some data we have very quickly. This is a study that I just finished analyzing the data and writing the manuscript as we do. It's an auxiliary study for a previous study called the Protract that was looking at clotting risk of DVT in pediatric ICU patients. We included 59 ICUs in 7 countries, and on 7 specific study days. It's a point prevalence study in 2012. So this way we're capturing the whole year, the 4 seasons, and we looked at what was the average hemoglobin in this population. Well, the average was about 11 grams. So this is kind of borderline low, isn't it? It's not necessarily anemia. It depends on the age. However, actually, the younger the age, the higher the hemoglobin. The higher the age in this population, the lower the hemoglobin, which opposite to what you see under normal conditions, as I explained early in my presentation. So that's one thing we came up. Also, whites had higher hemoglobin than blacks, and I don't know if that was a surprise. It was a surprise until I looked it up. Normal blacks in the United States have lower hemoglobin than whites. So there is some epidemiologic evidence of that. Actually, Asian has also lower hemoglobin, and when you go to the Asian statistics, normative values are reflective of that. So what we see is a microcosm in the ICU of what's prevalent in the community, in addition to the acute illness. About 1/3 of the patient had a hemoglobin above 12 grams, which is a surprisingly high number. 14% of the population got transfused on that day of the study. So again, it's very close to the Jacques Lacroix and Desmarais numbers of 17%. We also found that if you are in a cardiac ICU, your hemoglobin is higher. And it makes sense, right? We are overzealous with transfusion in cardiac patients. Location, if you are in Spain and Portugal, you have a higher hemoglobin than Asia and Canada. You're very close actually to the United States, but it reached significance with these 2 areas. Actually, we looked at the experience, how many years of experience the managing physician has. And it looks like those who have less than 5 years of experience, their patients had higher hemoglobin. So it's an alarming sign that the younger generation of our physicians maybe need to have better education. And then we looked at the gender of the managing physician. It was more in females actually than males that account for that. But again, those are not statistically significant numbers. These are trends that we're looking at more than anything else. We did regression analysis, and the location of the ICU, the geographic location, was significant in almost all of them, that you have to make adjustment when you're talking about what's the expected hemoglobin in that location. more interesting than any of this stuff, that also there was the history of complex cardiac, the complex cardiac history. If you have multiple cath, complex cardiac anomaly, veno-caval repair, all that was also a risk in some of those subpopulations. But the most important finding of that regression analysis that we did not find any factors associated with hemoglobin level in two groups of patients: those who have cyanotic congenital heart disease and those who have cancer, which tells you this is subpopulation that need to be targeted, because we are not transfusing them for anything logical that we find in this study. All these factors, none of them turn out to be significant in this population, which means that there are some other factors that we're not accounting for. One of them is what our perception is, what's good hemoglobin for them. So put it all together, it's really about the anemia and the transfusion and the balance, and the difference between what's optimal hemoglobin and what's the tolerance to that for the lowest hemoglobin is really what we're talking about. What's the level of tolerance? And it all depends on the circumstances. So how you approach this? Well, you prevent anemia, and that's a little bit beyond my talk today, but you really do your best, try not to get your patient to be anemic to start with. If they are in the community and the anemic detected and treated, and this is one of the projects we have at SABM here, we are getting into sometime soon, creating a campaign for anemia detection and treatment, but we're working on getting some funding for it. Minimize your blood losses for whatever reasons. We talked about phlebotomy orders, CPO orders, and all this stuff, and hemostasis. If you don't manage hemostasis, a small ooze from a line after a few hours will become big blood loss. We get this all the time, kids who have tonsils in a small community hospital, a little bleeding happening, and surgery in the morning, and by the evening they're calling us, the hemoglobin is 4. And what can we do? Well, there's nothing you can do at this point. You're at the part of breaking the compensation mechanism for this child. You have to treat them. Monitoring, I think when you have a bad anemia, there is no replacement for proper monitoring. It's not the number, it's the patient. So really look at their mental function. If their mentation, how good it is. If it's clouded, then their brain is affected. The level of activity, small babies become inactive. They don't grow. Their weight gain gets affected when they're anemic. However, none of those is really a straightforward answer, but they're kind of surrogate markers, but they're not really highly specific. But just keep that in mind. Tachypnea and tachycardia, compensation. Just you have to draw the line between compensation and decompensation. If somebody's tachycardic, yes, compensation, but if they have gallop, they have a larger liver, poor perfusion, then that compensation turned into a heart failure. And it's a usually bad outcome. And as I'll show you a couple of studies in a second. Monitoring blood gases. And more important, actually, than labs is the non-invasive monitoring, whether it's a NIRS technology or continuous hemoglobin monitor or pulse oximetry. All this stuff you need to assemble that monitoring environment that allow you to make an intelligent decision. So there is nothing smart about saying, oh, 7 is okay, I'm going to sit on it. No, this is the dumbest answer you're gonna make, and a big mistake, because you really need to look at the patient and collect the data that will make you understand this is a very well tolerable situation until you do something about the anemia. So it's a difficult decision. We have data on what's a safe hemoglobin. We don't have any good data on what's an indication to transfuse. So it's a little bit of a dilemma that we live with. So if you say, I have a trigger, then that's just, as I said, it's not a smart way of managing patients. Having said that, let's look at the studies that uses the triggers. Tri-PICU from Jacques Lacroix from 2007, and I got to hear it from him actually back in 2006. He came to visit us in Grand Rapids with the data. Showed that hemoglobin of 7 in stable ICU patients is adequate, it's tolerable. It's a non-inferiority study, meaning that 7 is as safe as 10. Okay, so he doesn't say 7 is an indication for transfusion. And following that, 3 other studies, sub-studies came out looking at subpopulation in this group whether it's surgical patients, cardiac patients, or sepsis. And all of them showed that 7 was adequate. Also, ventilated patients, which there isn't any single study that looked at ventilated patients and tolerance of anemia. However, almost half of this population in this study had lung issues, and they did as good as the other in the low group as well as in the high group. So you can extrapolate that lung disease, 7 gram of hemoglobin is adequate. Post-operative cardiac, I'll show you a study, but looks like we have some new data. I'll share with you in a second. Burn patients, Tina Palmieri showed that 7 also is adequate. Well, I think we're cheating from the adult literature by doing all the studies. Neonates is not as straightforward, and I think you got a glimpse of that when Susan presented some of this data. And the first study that came out from Bifano in 2002 was a very small data, then bigger study from Bell in 2005 in Iowa, then Kirpalani, the PINT study in 2006. And they deserve a little bit of look at them to make you understand. The first study I want to show is the Iowa trial, where we looked at transfusion trigger in neonates and the way they, premature babies actually, less than 1,500 grams, 28 weeks. And they have a threshold that varies depending on the level of lung disease they have. They varied from 46 down to 30, and the liberal versus 34 down to 22. They found differences between the two groups. The restrictive group had higher incidence of periventricular leukomalacia and IVH combined. Separate were not significant, but when they added them up, they were combinedly significant. And also there was a higher incidence of apnea in the restrictive group. So the conclusion is that restrictive transfusion in this study was not healthy, was not good, except that they came back years later looking at the long term of those candidates. They had 100 patients. They were able to capture 44 patients later on. I think it was like 12 years. They were like 8 to 15 years of age at that time. So it's like many years later, and did MRI on them. And when they did the MRI, their white matter, where the brain fibers reside, was less in the liberal group. And also, so there was some verbal fluency issues and visual and memory issues in the liberal group. So if you look at this, you say the liberal group had worse outcome. This is completely opposite to what they showed in the very first study. Okay, let me go back in time to Kirpalani study, which is bigger than the Iowa study. It came out, I think, the same year or the year after. Yeah, the same year. It had more patients in it, multi-center, and looked at high versus low hemoglobin. And they found that there's no difference between the low hemoglobin and the high hemoglobin in that group. So is it reassuring now? Because it kind of deflected the alarms that came out of the Iowa trial. It was the same year, so people said, oh, yes, don't worry about it. But really, when you look at their data and the analysis, the 2-year developmental analysis, they had more cerebral palsy and cognitive delay that almost reached significance. So with that, I'm going to leave you with this neonatal transfusion protocol that's from Robin Olds that was published a couple of years ago. It's probably the most conservative protocol. And again, it tailored the threshold based on the outcome. And there's a bunch of other protocols, but really as time went by, that threshold for transfusion went down and down from one protocol to another. And I think that's a decent protocol to adopt. Okay, how about pediatrics? The older kids? That's a tough one. And I go back to 1992 study, because really we don't have any data on severely anemic patients. So we go back to Africa, Kenya. This study came in 92, which is a prospective study looking at 2,400 admissions, looking at those who had hemoglobin less than 5 grams. 20% of those only got transfused. So really we had a control group, and mostly because of lack of blood availability. If the hemoglobin was less than 5, mortality was 18%. If it is more than 5, the mortality rate was 8%. It's a huge difference. So we know now that probably hemoglobin of 5 and less is going to get into an area where there is trouble. So if the hemoglobin is less than 4.7 and you have respiratory distress, if you transfuse that patient, your mortality rate decreases. So this is the odds ratio is 0.9. So this is the first piece of data that tells us transfusing somebody can save their lives. And if it's less than 3.9 also, and if you transfuse them within 48 hours, you decrease their mortality. If you wait too long, they are too anemic and they will die out. So really that was a very landmark study, because after that, many countries in Africa started adopting the hemoglobin of 5. And the same group came back and looked at group of patients with hemoglobin less than 5 and looked at those who got transfused and those who didn't get transfused. And the one that got transfused compared them with the one that more than 5, which didn't get transfused. And if you look at the numbers, it's very interesting here, because the hemoglobin less than 5 and untransfused, their mortality again was like 19.5%. And compared to the one that have hemoglobin more than 5 untransfused, I'm sorry, the other way around. If you are more than 5, your mortality was 19%. Less than 5 and untransfused, your mortality is 41%, which is twice as much. But if you transfuse them, this is the group that less than 5 and transfused, your mortality rate becomes very close to the one that above 5 that didn't get transfused. So it's about 50% change in swing in the mortality rate if you transfuse somebody if their hemoglobin is less than 5. Then the third study looked at retrospective study that came also from Kenya, from a different town, and looked at those who got transfused who had hemoglobin less than severe anemia, which is the definition of hemoglobin less than 5, or if he had altered mental status or respiratory distress. And certainly looking at those transfused and not transfused, again, there's a huge difference in the odds ratio of the mortality. So transfusion in this group obviously seems to be clear indication. I'm going to skip this for time's sake. So this probably one of the last two studies I want to show you. This one is in adult with traumatic brain injury, and I'm showing it because I don't have any pediatric data to show you. We don't know what's the threshold for somebody who has brain swelling or intracranial pressure, but this data showed the safety of hemoglobin of 7 versus 10. Actually, the ones that had, they did a follow-up in this adult group, I think at 6 months out, and there was decent, the favorable outcome was equal, but actually if you look at the details, the lower hemoglobin had better outcome. It just didn't reach significance. And then there was a higher incidence of DVT, thrombotic phenomena with the patient that were maintained at a hemoglobin of 10. This study is a little bit convoluted because there's also randomized to receive 2 doses of erythropoietin as well. But I'm not going to get into these details. The last group of patients I want to touch on, and I don't know how much time I have, 5 minutes. I'll do fast. Heart patients, as I told you from the study that I showed you, the Haem-PICU study, are very high-risk group, and we transfuse them in a mindless way almost. And I live in this environment, trust me, and I don't agree with it. So you have a heart patient, it's not really like adults where it's mostly or ischemic or a valve. No, in pediatrics, it's a lot more convoluted issue. You can have contractility issue, you can have somebody has cardiomyopathy, myocarditis, you have rhythm issue like supraventricular tachycardia, or you can have issues, anatomic plumbing issues that give you pulmonary congestion or obstruction of blood flow or mixing of the blood flow. Worse than that, you can have one side of your heart developed, the other one did not. Those are the hypoplasts. Those are like the nightmare in terms of management, regardless of the blood issue. So whatever you do for this group, they have one ventricle that didn't develop, the other one is okay. This is all what they got. So it doesn't matter whether it's right or left. You have to connect it with the aorta. Then you create a connection between the aorta and the pulmonary circulation. So you have 2 parallel circulations together, not one after the other, like in the normal anatomy where blood goes to the right side, goes to the lung, comes back to the left side, goes to the aorta. No, these are two circulations parallel to each other that are interdependent. You increase the flow and the systemic circulation will be meaning that you'll have less oxygenation. You increase the flow to the lung circulation means they have less cardiac output. You pick your poison. So they are really tough patients to deal with. So what happens to those patients in the OR? If you take them to the OR, and in the old days, we used to let the hematocrit drop to about 14, 15, no problem. We are hypothermic, they're on bypass, we have no issues. Until these two studies came out, and the first one randomized patient to a hematocrit of 20 versus 30, and certainly the one with the 20 had worse outcome. Immediate with high lactate, evidence of hypoperfusion. Also, the Bailey score of development a year out was worse. So we knew 20 is bad. Then the next study on the bottom randomized 25 to 35 hematocrit, and they were even. So when you a hematocrit of 25 is probably okay. So this is what we do. That's the recommendation of the Society of Thoracic Surgeon. Keep hematocrit above 24 when you are on bypass, hypothermic bypass. Did I say one more study? No, it's two more studies. The interesting studies, because this study revolved around the same population. This looking at 175 patients from a previous study that was done, looking at patients with heart disease and how often we transfuse them and what's the threshold. And this study just came out actually like a month or two ago. And if you look at it, there are 2% of the population getting transfused with the hemoglobin above 16. That's a crazy number. And 13% when the hemoglobin is 14. Who would transfuse a patient with a hemoglobin of 14 or 16? Then even 30-something, 34% if the hemoglobin is above 12. So you add all those together, it's a crazy number of transfusions for unjustified cause. So it's disturbing environment that we live in, that we are lightly transfused patients. And I can tell you, the heart surgeon, you get blood, stabilizes the blood pressure. Yes, but causes vasoconstriction. Where? In the pulmonary circulation and in the microcirculation. Is this healthy? No. And if you are aware of Harvey Klein's data in septic shock and transfusion, how they give blood, they improve their blood pressure, but 4 days later they have multi-organ system failure and they die. These are dog experiments. So I think we have similar situation here. We're excessively transfusing this patient with blood just based on our perception what's appropriate. And as I said, this is the finding that we had from the Haem-PICU study where nothing came out of the regression analysis. This study also looked retrospectively at transfusion in those who are 72 hours post-op. So they waited a little bit until they stabilized. If you transfuse them, you increase their brain oxygen with NIRS technology, only if their hemoglobin is less than 12 or so. If it's higher than that, yeah, you improve their blood pressure. Yeah, you increase their saturation, but really you are not improving their brain perfusion. Until this study just came out, this study hasn't been published, even in an abstract. I think Jill Chile from New York will be presenting this. She presented this last month at the Palisi meeting, and I wrote things very quickly because I knew she was working on this for the last few years, and I was very interested in the data. She randomized post-operative heart patients to two groups, high hemoglobin and low hemoglobin. If you are pink, or biventricular, it was 7 versus 9.5. If you are univentricular and cyanotic, it's 9 versus 12 grams. And they followed them up to 28 days. So that's the beauty of this, but also there was no exclusion. Everybody, regardless of how acute they were in the study. And they measured the lactate time, how high the lactate at more than 2 and more than 4. I'm sorry, the 4 is missing here. And looked at the transfusion incidence. Yes, the ones in the biventricular group had lower transfusion rate. It didn't reach significance to the other in the cyanotic heart group, which means that we're still transfusing them regardless of what threshold we do. However, this study showed that really we can drop cyanotic heart disease threshold down to 9. So it's a beautiful study. I'll see it published sometime soon. I'm going to skip the ECMO and I try to put things into perspective here. So anemia is common and transfusions are common. Both of them are morbid. So neither one of them is benign. So we need to ask ourselves, where do we draw the line? Well, we know hemoglobin less than 5, or if you have hemorrhagic shock, you transfuse. That's just a clear indication. You can let somebody bleed to death. If your hemoglobin is 5 to 7, this is the gray zone we don't know much about yet, but the chances are some patient probably will be okay. If your hemoglobin is 7, it's safe in patients who are stable, including surgical, non-cyanotic heart, respiratory failure, and even sepsis. Did I say sepsis? Yes. The recurrent recommendation is a hemoglobin of 10 in acute sepsis and 12 in acute sepsis in neonates. It's not evidence-based, but this is what the Society of Critical Care Medicine and American College of Physicians publish every few years. They haven't changed that, although you are aware of the TRESS trial that came out in October or was last year that showed that hemoglobin of 7 in septic adults is safe. So I think at some point, the sepsis guidelines will change. Hemoglobin of 7 is safe for non-cyanotic heart patients who are acute, and also hemoglobin of 9 is safe in acute cyanotic heart patients. 8 or the hematocrit of 24, we said if you go on hypothermic bypass is the safety threshold that we're talking about. In neonates, it's a variable thresholds, and we don't know a lot about patients with encephalopathy or increased ICP, but it's likely a hemoglobin of 7 based on Robertson trauma data that came out in 2014. We don't know about multi-organ dysfunction or ECMO. So there is a lot of things that we don't know. A lot of subpopulation, we don't know what's ideal hemoglobin for them, or at least what's tolerable hemoglobin. That's a more important question to answer. But really the bottom line, regardless whether you have a trigger or not, you need to monitor the patient with equipments and also clinically and tailor the intervention based on the situations. The TAXI group is last word I'm going to leave you with is the transfusion and anemia expert from the Palisi BloodNet subgroup. We are a group of people, all of us are intensivists. There's about 35 of us. Some of us are not pediatric intensivists, like Jeffrey Carson is one of them, Arya is one of them. And we're looking at transfusion triggers in the ICU and in different subgroups of patients. So whatever talk I give today can change based on what we're going to do. And we just put our search queries, and hopefully we'll start looking at the data. And another year or so, we'll have some more information. I'm hoping that Stacy Valentine, that's leading this from Boston, that she will come to our next step, a meeting to give us a talk on this. Hopefully I'll see some of you in September in my hometown, and hopefully we'll get you some more information than what I just mentioned now. Thank you very much.